Hello, I'm Sarah O'Flanagan. Usually I'm behind the scenes, but Dr. Nicholson is on vacation. So I'm here to welcome you and say thank you for joining us today. We're thrilled to welcome Dr. Ashan Veerakumar as our speaker this afternoon. He is a PGY4, so a fourth year psychiatry resident here at the Schulich School of Medicine and Dentistry, and he's based at our Windsor campus. He completed both his undergraduate degree and his medical school at the University of Maryland. And he has a special interest in developmental disabilities and specifically self-injurious behavior. He's presented on this topic at multiple conferences, research days, as well as at our Department of Psychiatry's grand rounds. So welcome, Dr. Veerakumar, and I will pass the floor over to you.
All right. Good afternoon, everyone. I'm going to share my screen and get us started. Hopefully everyone can see the title screen. So as Sarah said, I'm Ashan. I'm a PGY4 psychiatry resident at Western. And I have to say that this presentation does tempt imposter syndrome a little bit because I'll be following past and future mentors of mine. So Dr. Nicholson and Dr. Friedlander have presented on this very topic. But I do hope that this presentation will reflect a fairly formative journey of mine, which was to try and care for those who are suffering, but cannot tell us why they are suffering and cannot tell us very easily how to help them. And if your attention holds for the Q&A, I'm here to learn as well as to share knowledge on this pretty difficult topic. So as a resident, I am young enough in my training to have a bit of sense of humor about conflict of interest. So I will see if I will declare that I'm a Star Wars fan without a Disney Plus account. So if somebody could help me with that, I'd be very appreciative as well. And then I do want to talk about the objectives a little while longer than usual. I want to talk about the context of this. So this talk emerged from a case that I encountered in my PGY3 year, which was one of the most challenging cases I had ever come across. And it led me to read up on the subject a lot and present a poster at the Health and Wellness for Developmental Disabilities conference 2 years ago. If I'm presenting right, you'll find yourself confused about what to do next with this case because it is complex. And from there, I'll take you through what I've learned about self-injurious behavior in this population. We're looking at the onset of self-injurious behavior can help us understand what to do next, how the location of self-injurious behavior could inform us, what the function of self-injurious behavior can do, and what the associated symptoms can tell us, what could be driving the self-injurious behavior. And hopefully afterwards, we'll return to this case with
Dr. Veerakumar, we aren't seeing the slides advance. I don't know if you're trying to advance the slides, but I'm still seeing your title slide.
Okay. Let me try this again. I might try not using the presenter view just to, is it?
Yes, I just saw the objectives just before they shrunk down.
Okay, I'll try again. I guess now it's okay, right?
Yes, now I see the objectives and your cursor moving around.
Okay, cool. Just 1 second so I can get my notes available. If I can. Yeah. So hopefully that with our tour of the phenomenology of self-injury, we will have a better idea of what this. I won't say that I've solved this case, but I will say that maybe we have a few more thoughts to add to what to do about this very challenging case. And at the end, if there's time, a very varied audience of trainees and practitioners in many different health professions or other professions can grill me and have at me with their questions. So who is this case that I've been mentioning, that has been challenging me so much that made me feel even like an 8-year-old at some points? So this individual is Miss A. She is roughly, I've disguised the ages a little bit just to preserve confidentiality, but suffice to say she's around 30 years old, and she's living with her adoptive mother because she was adopted from Romania. And anyone who is interested in attachment will understand what it means for someone who's around 30 years old to be adopted from Romania. They'll understand what this means. This implies that there could be a attachment disorder of some sort. Indeed, a cohort of children who were adopted from Romania were the ones that were studied that led to the diagnosis of reactive attachment disorder, a disorder where pretty extreme levels of emotional neglect will lead kids to develop traits that mimic classic autism. So this person already has this history. She was adopted at age 2, and it became apparent pretty soon after that she was severely intellectually disabled. She would not speak very clearly. Her communicative ability would be pretty low for the rest of her life, and her ability to do basic tasks unsupervised would be challenged for the rest of her life as well. But in addition to the self-injurious behavior, she began developing a very concerning self-injurious behavior. In particular, she would start striking her orbit with her knuckles. Once an area of skin got bruised or bled, she would strike an adjacent area until that too was injured. Frequently, she would miss the orbit, which is the which is basically the outline of skull surrounding the eye, and she would strike the eyeball directly. And of course, this behavior is quite concerning and quite challenging to manage just with parental interventions alone. So a lot of specialist help was sought. And different centers across the US were a bit at odds about what to call this behavior. That she was severely intellectually disabled was beyond doubt. And maybe they were thinking that this was an example of stereotypic movement disorder with self-injury. But some thought that this was an example of reactive attachment disorder, given the Romanian history. And some thought that this was due to autism spectrum disorder, that this was an example of ritualized behavior in a pretty tragic sense. So if head scratching could be described as a form of self-injurious behaviors, hypothetically, her behavior would be quite contagious because many people were scratching their heads about what to do next. And her behavior would spread in a different kind of way. Her behavior would start injuring other parts of the eye in ways that is not common. Indeed, I learned that there's something out there called traumatic cataracts that can be caused by multiple injuries to the eye, and she had developed this. And eventually she was admitted for residential treatment at the Kennedy Krieger Institute at Johns Hopkins. And to get an idea of how sophisticated this facility is, they will design at times entire classrooms based on research principles with sophisticated control and experimental conditions. They have that kind of level of funding. So one of the better known centers for developmental disabilities care admitted her. And there they tried various methods to try and help her. At one point, they tried to restrain her arms just to see if that would decrease the amount of injuries. And then they found that she began striking her orbit with her knees. And at one point, she tragically detached her retina. And to prevent a necrotic injury of the eye, they had to remove the eye. At the Wilmer Eye Institute at Hopkins, her right eye was enucleated or removed. But unfortunately, she would continue to strike her orbit after the eye enucleation. So her remaining eye is being struck, and she's, as far as I know, currently at risk of blinding herself and losing one of the remaining faculties that she is able to have. Her behavioral analysts have maintained that the self-injurious behavior is internally generated or automatically reinforced. Those two terms are synonymous. I will get into what this means. I will revisit it so we can all understand it. But suffice to say, this means that professionals who are trained to identify very subtle cues and subtle consequences that could be reinforcing this behavior could not find a clear reason for why she would keep hitting herself and striking her orbit the way that she was. So her behaviors continued to worsen, and they eventually started around adolescence. She started developing other behaviors that were not present before. She would become less mobile, she would move less, and she would require more prompting than she would require to do her usual behaviors. She almost looked frozen. And at this Kennedy Krieger Institute, there's a pretty prominent child psychiatrist, Dr. Wachtel, who is trying to advance the concept of a disorder called autistic catatonia, and defining what catatonia looks like in autism. So she diagnosed, with her knowledge and expertise, diagnosed this patient with autistic catatonia. And when she was old enough to receive ECT, she received roughly hundreds of electroconvulsive therapy treatments, and there was a partial improvement. But this turned out to be a bit of a false dawn. After the multiple behavioral interventions, medical interventions, and shock therapy, bone started hitting bone again. And eventually she was referred to specialists who are ready to go through a cranium to try and save somebody's life. And suffice to say, enter the functional neurosurgeons. And as these surgeons found, as they may have found during their neurotrauma rotations, this patient was bleeding at the perioperative assessment, at least according to the documents I read prior to the surgeries. So what ended up happening? She first started off with, well, firstly, I'll talk about how neurosurgeons and neurologists think. I'm not an expert in these fields like they are, but I've researched and worked with them enough to know a bit about how they think. They like to localize a lesion and to treat it in some way. And so their hypothesis was there is some electrical circuit in the brain that is causing her to injure herself. And if they disrupt nodes in that circuit, that they can stop the self-injurious behavior. And in particular, this literature emerged from treatment-resistant obsessive compulsive disorder. So the thing they tried first, if I remember correctly, was a lesion of the cingulate cortex, so in the upper and the middle and the frontal area of the brain. They lesioned it and caused a cingulotomy. And according to one of the clinicians who was there, this produced the most robust response. It actually made the self-injurious behavior disappear. But only for a short time, the self-injurious behavior returned. So faced with this challenge, the neurosurgeons tried again. They readjusted the stereotactic frame and positioned themselves to lesion other parts of the node. They went to the medial temporal lobes, so to the side and to the lower area of the brain, and they lesioned the amygdalas. And they also didn't stop with lesioning the nuclei of the amygdala. They looked at connections from the amygdala to the frontal lobe, and they caused an unsulate fasciculotomy. And they did this with so-called gamma knife radiation. And then they adjusted their focus more inwards in the brain and looked at the basal ganglia and looked at the ventral portion of the basal ganglia and did a subcaudate tractotomy and hit the ventral striatum, hit the nucleus accumbens as well, and did a nucleus accumbatomy. And they hit the internal capsule as well, fibers that connect the brain to the spine. A certain portion of it, they lesioned it. And by the time I arrived, they had taken note of some potentially encouraging literature from Brazil that found if you apply deep brain stimulation to the posterior medial hypothalamus, that you could decrease aggressive behavior and potentially self-injury in severely developmentally disabled individuals. By the time I arrived on rotation on an elective in Atlanta, Ms. A had received these surgeries and received deep brain stimulation of the posterior hypothalamus. So before I get into what the effects of these surgeries were, I want to take a little detour and maybe address some questions some of the clinicians in the audience are asking, which is what medications she was on. And to try and present this, I will borrow from what the classic textbook of psychopharmacology, Stahl's, will do to try and convey how medications work, where there is a colored ball or circle to convey that it is one drug, and multiple shapes with labels to communicate the mechanism of action. So when we put all these colors together, all these different medications together and tally up what neurotransmitter systems are active, we see a few things are going on. We see that the arousal levels that could lead one to be aware of anxiety as well as normal stimuli, that has been decreased. It has been decreased by increasing the GABAergic activity, which is in blue. It has also been decreased by decreasing the noradrenergic or NE system. And also sedation that could potentially decrease the volume of self-injury has been achieved by inhibiting histamine, much like a Benadryl, and also by inhibiting the muscarinic acetylcholine system to cause some cognitive blunting. And additionally, to the degree that, at least from a drug principle, some aggression can have an inappropriate cause, just like if there's a delusional cause. They have looked into looking at antipsychotic medications and have blocked dopamine and part of the serotonergic system, the very receptor that LSD acts on. They have blocked those, and in an attempt to decrease potentially inappropriate use of aggression or anger. And overactive neurons that from a disease sense may be overfiring are being decreased by decreasing glutamate and decreasing the voltage-gated sodium and calcium channels. Each of these, what all of this is called from clinicians to pharmacists, is polypharmacy. And this is a polypharmacy regimen that we sometimes use in our most challenging cases, where we try and, just like the neurosurgeons try to hit every node that would underlie a circuit, we try and hit every neurotransmitter system that could be at play in somebody's illness. And I don't have the exact pharmacologic history, but she has been on several different medications before these. So now with all the meds and with all the treatments and with all the surgeries that I've done, I want to give you my impression of what Miss A was like when I examined her. To briefly give a mental status exam, there were no observable tic-like behaviors such as in Tourette's. I could not see her face clearly because she was wearing appropriate personal protective equipment, but her eyes were not very furrowed. They appeared relaxed. In my assessments, she was not bleeding from her self-injury like before her surgeries. She was well dressed and groomed, and she was clutching what appeared to be a decades-old stuffed rabbit the whole time. Her right eye was visibly fused shut after the enucleation. I noticed that her mother would always have a hand on her at some point during the assessment. Doesn't matter where, but she did not leave her daughter alone physically. If one would greet her, she would quickly make eye contact and make an unintelligible vocalization. At most, this vocalizations would have maybe 2 to 3 pitches. None of us could understand it, but apparently her mother could and would translate. The first assessment, she would clutch onto the rabbit very tightly and barely look up. And in the second assessment, she had a more relaxed posture. However, at home, she continued to be injuring herself. And by the time we ended the session, or by the time I ended my rotation, she was they were considering going back to ECT because they did not see the DBS as a very robust treatment after initiated. So if I presented correctly, we'll all be feeling pretty confused at this point. This person seemingly has optimized medical and neurological care. She does have epilepsy, which is being treated and monitored by neurologists. And at least on the exam, and I'll get into how we can do this later, she did not appear to be in pain. We have, as I've mentioned, we have seemed to maximize our pharmacological and psychosurgical interventions, and she continues to get behavioral analysis to try and decrease this behavior. And her social service connections are strong. So with all of that, what can we do next? So when I left this rotation rather confused about how to care for this person, I tried to read into the literature to adjust my perspective a bit. I wanted to ask myself, how could I view the self-injurious behavior perhaps a little more precisely? And then maybe after doing so, I'll ask, what could we do next? So a way that we can go about tackling a problem that has no fundamental solution available to us is to engage in what we call phenomenology. So until that we have a particular lab test or a particular genetic test or a particular physiological pattern, what we can do is study what is observable to us without thinking about the cause as carefully as possible. And I can say that that this topic is vast, but I'm going to focus on 4 elements of what could be called phenomenology. The idea here is that if we pay very careful and precise attention to the onset of the self-injurious behavior and the location of the self-injurious behavior on the body and the function of the self-injurious behavior and the associated symptoms with the self-injurious behavior, we might have a sense of how to guide treatment. So firstly, we will look at the role of time. And time, of course, can be measured on multiple domains. We could think of when self-injurious behavior happens during the day, at what minute does it occur, or what frequency does it occur. But right now I'm talking about years. When did it start? What year did it start? And before I get into the numbers a bit, I want to say that for someone who cannot communicate to you why they are injured or why they are distressed, self-injurious behavior can become that mode of communication for many of these functions. So that means at any age, we have to be alert to the possibility that there could be a medical illness that is driving the self-injury. At all ages, this could occur. At all ages, they could be in pain. In childhood, they could be having strep throat, or they could be having an ear infection. And when they're adults, they could have more adult diseases that could cause them distress. But from the age of 2 to 11 years, self-injurious behavior can emerge independently. What does happen to many kids of any developmental level is that they will, as they're exploring and testing limits, might injure themselves, and they gradually learn to speak and gradually learn consequences, and then they stop. But those who are more disabled will continue engaging in this behavior, that would go away for many in childhood. And once again, at any age, there could be a medical crisis that causes self-injury. But once we get to 11 plus years, we start finding that there could be more psychopathology that does not occur neurodevelopmentally. So not even ADHD or autism, things like anxiety, mood, or catatonia. And stay tuned if you're asking, how do we find out if someone has a mood disorder or psychosis or anxiety? We will get to that when we talk about associated symptoms. But suffice to say, at successively later years, if self-injurious behavior is developing for the first time, we may see some evidence that this is caused by a treatable psychiatric illness. So let's move on now to another domain of the phenomenological characterization of self-injurious behavior. let's look at the location of self-injurious behavior. So on the right, we have a diagram looking at the body surface area. So 9% implies that 9% of one's body surface area is the front of their face. Now, if one draws their attention to the left, one can see that when studied, headbanging and hitting is much higher than 9%. This little piece of surface of the body's real estate is overrepresented as a site of self-injury. And if we remember the story, if one tried to restrain Miss A's arms, she would even use her knees to access her head as a site of self-injury. And some studies about why people were admitted to Kennedy Krieger's behavioral unit, when individuals, and perhaps some individuals who may have treated Miss A in the past, when they looked at the functions of the behavior, which we will get to, they found that many kids with autism who had a very clear socially driven reason for their self-injurious behavior would injure several spots on the body to a low degree. But some patients who had no clear cause for the self-injurious behavior, had very high degrees of intellectual disability, would seem to concentrate their self-injury on the head and cause severe injury to the head. And with our knowledge of the timing of self-injurious behavior and the location of self-injurious behavior, we'll start to ask ourselves some questions about the functioning of self-injurious behavior. This is what all the applied behavioral analysts involved in Miss A's care and other kids with autism are trying to understand when they are engaging in self-injurious behavior or any problem behavior. They're trying to ask, what is the function? And this is a vast topic of which I am not an expert. Hopefully we can engage in a discussion if there are any BCBAs present to learn more from them. But one way to simplify what the function is to ask, what is the antecedent and the consequence of the behavior? And the way I have tried to understand this for myself is to break it down a little further. We can look at antecedents as coming from somewhere outside the self, be it social or within the self, something about the body, something in the mind that is causing it. So if we have a little, and the consequences of a self-injurious behavior could be to seek something good or avoid something bad. So if we look at this grid and think of what is something inside the self that they don't like, they're trying to cope with it and trying to escape from it. This is where we can think of psychopathology and pain. If these come up, someone may engage in self-injurious behavior to try and manage it. So as mentioned before, self-injurious behavior can be an index sign of several forms of distress. And if we go down the grid again and start looking at something that is avoided that's coming from outside, a social thing that they're trying to avoid. Many people find that kids who cannot express themselves well, who are trying to escape a conflict or escape a task that they don't want to complete, may engage in self-injurious behavior to avoid it. And moving again, but this time thinking about positive things that they're seeking. Sometimes someone may injure to seek attention. And this is a field that is still under investigation. If the Bucharest study, the Romanian studies have taught us anything, it's that even emotional neglect can cause some pretty profound symptoms. We're still trying to decide what is a trauma for someone who is intellectually disabled. Should we consider trauma in the exact same way as someone who is not? Should we relax the criteria we have developed for trauma? And of course, many are starting to appreciate that maybe there are some attachment behaviors at play with self-injurious behavior, and maybe attachment-based interventions will help. And finally, sometimes people self-injure themselves because there's something inside them that they're seeking. There's something within them that seems to be wanted or at least sought after with this behavior. And this is called automatic reinforcement. And some BCBAs who likely treated Miss A developed a classification system of different types of automatic reinforcement. Subtype 1 decreases during play conditions. So if you were to remove sources of enjoyment from the room, you'd find that they'd start injuring themselves. And another type, subtype 2, there appears to be no difference. If they have things to do or don't have things to do, they'll injure themselves. And some have hypothesized that at this point, there is something just habitual going on. And subtype 3 is where there is self-injury, but there's also a self-restraining behavior where sometimes they're injuring themselves, but also trying to hold themselves down without any input to try and stop themselves from injuring themselves. And there have been many studies that have variable results when one tries to understand what percentage of self-injurious behavior is caused by a social problem or an automatic problem. The problem is because we don't exactly agree on what self-injury is. I can definitely find some members of my family that would call nail biting self-injurious behavior. And I could imagine other people would not think that is self-injurious behavior at all. That's just to say that we don't always agree on the terms. But regardless, what is clear is that a substantial amount of self-injurious behavior studied, or at least coming to the attention of clinicians, is caused by automatic reinforcement, where there is not really a clear cause of the behavior. So with the functioning reviewed, with the locations reviewed, with the timing of self-injurious behavior reviewed, we're going to come to our last concept in phenomenology, which is the associated symptoms. Much like if we blind ourselves as clinicians and we started just examining one part of this organism, and one clinician says, oh, the trunk, this trunk-like object is deformed, or another says this tail-like object is not working properly. We may be overly focused on one area, and we'll have to step back, unblind ourselves, look at the whole organism, look at all the features together, and we might find that some clear diagnosis leaps to our attention, some clear concept leaps to our attention. So we will take this approach of looking at the associated symptoms with self-injurious behavior when looking at mood, anxiety, psychotic disorders, and pain. So how does one express a mood disorder if they cannot tell you they're depressed? How can someone describe bipolarity or mania if they cannot convey a grandiose idea, if they cannot tell you that they're a billionaire when really they're not? One way we can do this is to look at their skills very carefully. If we have a perfect understanding of what this person is like at their best and how they communicate at their best, we can look at changes from this baseline when thinking about depression. If, for example, they have a set of skills and if they lose some of those skills, and then start not eating properly and start not sleeping properly and withdrawing, this may be a depressive episode, even if they can't tell you. And similarly with mania, some people cannot speak, but they may learn some degree of communication, whether it's American Sign Language or just whatever they could come up with themselves. The fact is, if somebody is manic, they will engage in more nonverbal communication. And if one can speak in a very pressured and quick way, one can do signs in the same way if they're manic. And there'll be increased psychomotor activity. The most easy sign to identify with mania in this population is irritability. And for those who can speak more, there is a curious phenomena where the grandiosity is relative to their position. So the classic example is somebody who is wears diapers and is dependent on feeding may suddenly believe that they are a taxi driver. Now, many of us may not see this as a grandiose idea. We may see something as being a billionaire as a grandiose idea, but to them, that is a grandiose idea. So we have to pay attention to the social circumstances as well. And if we accept that the body keeps the score, then the sympathetic nervous system are some of the notes. And during anxiety, if somebody cannot tell you that they're anxious, the sympathetic nervous system may be playing some very loud, discordant notes. If somebody cannot tell you that they're anxious, their pupils may still say that they're anxious. They may be sweating. They may be breathing faster than usual. Their heart rate may be going faster than usual. And they may be seeking escape. And if one is trying to think about psychosis, one will have to contend with the fact that much of the behaviors of those who have intellectual disabilities look a lot like psychotic illnesses in some shape or form. Indeed, the original Kanner description of autism way back in the day was one reason for that paper was to distinguish what he was observing, which turned out to be autism, from childhood schizophrenia. And part of the way he diagnosed it was the earlier onset of the autism spectrum disorder than the childhood schizophrenia. So we'll have to know the baseline of all the somewhat odd behaviors, if that could be an appropriate term, that could be confused with psychosis. If we know that at baseline, we'll be able to spot changes. So unfortunately, one is sometimes tempted to engage in an almost callous sounding exchange when someone is conveying symptoms. My kid is flapping their hands. Well, what's new and exciting? They are speaking to themselves. Well, what's new and exciting? They are hitting themselves on the head. What's new and exciting? Now, it doesn't go exactly like that. We're taught to communicate in a much more compassionate way than this, but that does illustrate the point, I think, that we're looking for new signs. And similarly, given that the brain is developmentally impaired, we may see more non-auditory hallucinations or perceptions at play. Just like when someone has a delirium or takes drugs, they may get more visual hallucinations. It has been reported that those who are developmentally disabled may be more likely to have the non-classic visual hallucinations, even if they do have true schizophrenia. So if there's one concept that is pretty universal to care and to distress, maybe pain is that one, especially because pain is subjective. So how then do we measure pain in those who cannot tell us they're in pain? Again, Osler once said that if you just listen to the patient, they will tell you what's going on with them. Well, what happens when the patient cannot tell you what is going on? So pain in the developmentally disabled population is an active area of research. I can give you a bunch of scales. I've listed some here, but they share something in common, and it's hinted in the name in one of them and in the picture. And that is the facial expression. So when someone is in pain, the facial expression will change. The eyebrows will change, the mouth will change. Dr. Nicholson and I once interviewed a mother of a patient with either profound intellectual disability or intellectual disability and cerebral palsy. This person was completely bedbound, completely dependent. And the mother noticed that when her son would pout and then start thrashing, she noticed that if she opened up the feeding tube and vented it, and basically got some of the bloat out, that it would stop. And that facial expression wouldn't come about for other forms of distress. So if I were to be almost immodest, to be a resident proposing a change to the time-honored mental status exam, what I would nominate is to add a category for physiognomy or facial expressions to the mental status exam, because this can be an interesting way of potentially detecting pain. And I do see that there's a Q&A. I will try and get to it in due time. Sometimes the associated signs can be freezing or needing to be prompted to do things, or if they can speak, engaging in echolalia, or engaging in echopraxia or mimicking gestures. This could be catatonia, or this could be obsessive compulsive disorder. So this idea of catatonia in autism remains a controversial diagnosis, but it is being proposed as potentially a driver of some self-injurious behavior that appears automatic in nature. And the criteria that have been proposed, interestingly enough, catatonia is one of the few, it may be the only psychiatric diagnosis that can be, maybe besides panic attack, that can be observed only without any questions having to be asked. But at the same time, it is still made more difficult if the patient cannot speak. It is, with all of this, it is hard to differentiate all of these symptoms from obsessive compulsive disorder in this population. So now we're nearing the end, and maybe all of you have aged as much as Lisa has in this picture, in these pictures. But knowing is half the, at this point, we have to also consider that knowing is half the battle. We also have to try and treat, and we have to try and support. How do we manage someone who has self-injurious behavior? And again, I'm not an expert in behavioral analysis. There are many people who can speak with much more eloquence than I can in this audience, likely. But we can focus on the antecedents and modify things directly by behavioral interventions. These are antecedent-based interventions. If there is a reinforcer of the self-injurious behavior, we can take control of it and deliver it on our terms. And therefore, the patient may start not associating the behavior with the usual reinforcer. This can be effective, but it doesn't train any pro-social behaviors as well. Also, non-conditional reinforcement. Many patients have what's called frustrative non-reward, as some have called it. They cannot, and one example is that they cannot tolerate a delay in a reward. If it's hard to tell someone who is disabled, oh, you're going to get this in 5 minutes if you can wait. So one thing that is being done is non-conditionally providing something they want. And this can be from a competing stimulus assessment where they systematically give things that could be preferred and watch if that decreases self-injurious behavior, or if preferences are known, implementing them, or doing both. And an idea that could be at play with Miss A is that so long as she has access to her toy rabbit, no matter what, not as a reward for self-injury, never, and not as a reward for doing good things, just access it all the time, she may be less likely to self-injure. And ideally, and restraint is in scare quotes because this could even be called a punishment. And consequence-based interventions are varied. They can mean that we are reinforcing alternative, other, or incompatible behaviors with the self-injurious behavior, or even lower frequency of the self-injurious behavior. Or in the academic sense, this can include punishment. And that means actions that are taken directly to decrease the frequency of an event. This can range from telling them to go exercise or to clean things as a response. It can range from taking toys, and in one center in Massachusetts can even lead to shock therapy, thoracic stimulation. What is being, and essentially how do we view punishment? It remains controversial for a good reason. Yes, it could be effective, but when a review was done on ethical standards, it found that many of the punishment literature, it wasn't clear who was following rigorous ethical standards and who weren't. And even at the center doing thoracic stimulation, 2022 task force report on this center found that Yes, punishment may be effective, the thoracic stimulation may be effective, but it was used inappropriately at some points. So it's essentially not used as much because it's not clear who is following a very clear-cut, onerous ethical framework prior to engaging in this intervention. And with these behavioral interventions, communication is also a goal. If our whole problem is that they cannot tell us what is going on, this can be a goal of the behavioral analyst. And when it comes to medications, I know you're probably all exhausted, more exhausted than I am. Thankfully, I won't have to talk much about medications because there are so few that have been studied. Risperidone has very, very good evidence in aggression and autism, and one can study the scales carefully and extrapolate reasonably to self-injurious behavior. It suggests that there might be a dopamine component that is necessary. Naltrexone has also been studied, as a recent Cochrane review has shown, for self-injurious behavior directly. And an emerging topic, at least at the case series level, is deep brain stimulation of the posterior hypothalamus. But before engaging in these recommendations, as always, try and do everything else. If there's a comorbidity, treat it. If there's a sleep disturbance, treat it. If there's pain, treat it. And if there's behavioral interventions available, do those first. So if we're going to put all those together, I know we're running a little over time. I'm going to wrap up soon. If we're going to put all of this together and consider the phenomenology, we're essentially going to try and lead with behavioral interventions first. And in parallel, so also first, treat comorbidities and treat what else can be treated without getting too focused on the self-injurious behavior. And if the applied behavioral analysis is not working, and the regimen is up to the BCBAs who know how to do this very well, if that's not working, the medications can be added to augment it. And once the behavioral management plan is successful, one can potentially remove the medication. And again, this could be a discussion point, but the best I can come up with in terms of what to do behaviorally is to give a treatment package, which means do multiple things at once. One can do a stimulus and a preference, or sorry, a competing stimulus assessment and a preference assessment to find the right non-condition reinforcer. One can at the same time try and use functional communication to reinforce communications of distress that can be noted later. One can reinforce a more preferred pro-social behavior. And one can take several measures to even test the slow withdrawal of services to prevent extinction bursting. But with all that aside, we can use medications to help, provided the comorbidities are treated. So wrapping up, if we're going to think about self-injurious behavior, we can do so by mapping the injury, timing the injury, looking at the function of the injury, and looking at the associated symptoms. And from there, if we take care of the comorbidities and engage in a compassionate and iterative intervention, behavioral intervention, and use medications just to augment it, we could make an impact. So revisiting this case, we have someone who had pre-adolescent onset of self-injurious behavior. It was concentrated to the head. Behavioral analysts could not find at this point a clear cause, and they called it automatic reinforced or internally generated. There was some extinction bursting going, and there was perhaps some elements of non-conditioned reinforcement being successful. It is possible that there were no consistent associated symptoms, and this was purely independent. But it was true that as an adolescent, there were features that suggested potentially catatonia versus OCD. And what does this mean? This could mean that from a pharmacological perspective, we could ask the question, was risperidone or clomipramine tried? Was there a reason why we can't use it? Because maybe that is the most effective. She may be a high-dose naltrexone candidate, given the evidence available. And sometimes we also need to retry our behavioral interventions. Sometimes the self-injurious behavior can acquire new purposes, new functions over time. So sometimes we just have to start from scratch and see if there's anything else we can learn. And as we learn more about attachment, we should try and look into this possibility as well. So I want to acknowledge the invaluable mentorship that I've received from Dr. Rob Nicholson, Dr. Montaglioni, Dr. Brian Burke, and Dr. Riva Pose of Emory. He introduced me to the latter, introduced me to the case, and wrote a letter for me to get into residency. So you kind of know who's responsible for me being here today. And for those who have given me their time to introduce me to the basics of applied behavioral analysis, I want to thank Patty Peterson and Dr. Robert Babcock of Auburn and Emory University, and the lectures and discussions I've had with Dr. Jay Rao of Parkwood and Western. Those are a sample of my references. I want to thank you all for attending and open up for questions. We'll see if a Martin Prince is among us.
Thank you so much, Dr. Veerakumar. As you mentioned, I think there is a question in the Q&A from Dr. Goldberg. So do you want to take a look at that one first?
Sure. Has she ever been seen by a developmental pediatrician? That's a great question. I wish I asked that to begin with, but I will say that each of the clinicians involved have several patients on their roster who had clear congenital syndromes as well. So I'm going to infer that they would have found it. For example, on the same day that I saw her, I saw someone who had self-injury with Rett syndrome, and that was very much a part of our formulation of that particular patient. Okay. The chat was just about the previous problem of the slides advancing.
Yes, yes. So if anyone else has questions, you can either raise your hand or you can type it in the Q&A. I think I saw Patty Peterson had joined at one point, so I don't know if she has anything she wants to contribute to the discussion or anyone else has a question. So this is what the third or fourth time I think I have seen you present about self-injurious behavior. What is it that really piqued your interest and made you so interested in this area?
Yeah. Also, I do have to say that one of the jobs of a resident is kind of do what's asked, and I was kind of asked to do this presentation a few times, and I'm happy to do it. But you're right, there is an interest that drives all these presentations. And I guess it starts with me liking very complex problems as a clinician. And I see few things more complicated in psychiatry than to understand what pathologies are at play when somebody is not able to express themselves in the usual way and not able to attend to tasks in the normal way. I also felt in this particular case that it defied simplification. Most of the neurotransmitter systems, as I mentioned, were, at least they tried to optimize those. Neurosurgical interventions, for example, even if we think that she didn't have catatonia and had OCD, she had all the last line surgeries for OCD. So when everything that we have tried seems to come up with no particularly good answer, that gets me quite interested. And I think there's a lot of that in developmental disabilities and in self-injury in particular. I see a question here.
Yeah, I think I was just going to say a question in the Q&A from Dr. Lowe.
Yeah. I wonder if an interictal syndrome was considered given the presence of epilepsy. Did she have EEGs while treated with anticonvulsants? That's I don't know if the particular EEG question under regimen was done. That is a good one. What I can remember is that I think she was trying on a lot of anti-epileptic medications. She's not only seeing a psychiatrist, for the DBS, but also just for routine clinical care. She's also seeing a neurologist just for the epilepsy as well. And at least what I remember is that the communication is quite strong and constant about this case. So a good question is asked, in your opinion, was she traumatized by all the medical interventions? That has to be kept in mind. At any point when a treatment is not working, we have to ask ourselves, did we get the diagnosis wrong? And that is often the case when we're, and that thing that is often, and when we often get the diagnosis wrong, the reason we often get the diagnosis wrong is because we don't consider trauma enough. So certainly one has to ask that question. The question is, what would one do about it? I guess it would take a clear case conference discussion where we would look at the risks and benefits of all these procedures and decide whether a complete wean of all the stimulations are, for example, are going to, like the DBS or electroshock, all of those are appropriate, and then do a very clear behavioral analysis and to try and understand whether there's what the cause is. And potentially there is an emerging literature on how we can introduce attachment, which would help with the trauma. For example, simple things like having a very present but flexible clinical team that will interact with the patient in a similar way so that potential traumatic attachment patterns aren't re-triggered. These can be arranged with careful teamwork, but that is a good question that there isn't a clear answer for.
Okay, yeah, and Dr. Goldberg, I'm going to allow you to talk here. If you raise your hand, oh, never mind, I see you. All right, if you unmute yourself, you can probably speak now, Dr. Goldberg.
Yes. Well, first, I'd like to congratulate the doctor on an excellent review of self-injurious behavior. Just wanted to comment on the treatment of self-injurious behavior during my years at CPRI. There are two major movements in that direction. One was thoracic stimulation, and I chaired the thoracic stimulation committee for the province to ensure what you just indicated was ethical review. And there was only one facility in Ontario that would do this, and that was a Southwestern Regional Center under Dr. Barrera. And when I left the practice, I still consulted with the remaining thoracic stimulation patients, and they gradually decreased and were successful, positive, and was very well done. The other movement was headed by Dr. Dieter Blindert, intensive ABA, in which there was positive reinforcement for lack of self-injurious behavior. The big problem with that was the intensive staffing that had to be required. And I spoke with a behavioral therapist just the last month, and that is one of the major problems of doing intensive positive behavioral interventions with self-injurious behavior, because one has to enlist essentially 24-hour staff to do this. And so there's a major funding problem with that. So there are two approaches which have been successful. And as I indicated in my earlier question, there are a variety of congenital syndromes like Lesch-Nyhan and Prader-Willi that do have SIBs. That's where the importance of the development pediatrician. But in general, I think you've done an excellent review of the literature. Thank you.
Yeah, thank you very much. And thanks for also confirming that some patients were able to be weaned from thoracic stimulation, because the most recent thing I read was casting some doubt on that, of course, on a very small sample. So that's encouraging to note. And even in the poster I did, I briefly touched on the congenital malformations, but that, of course, is even the pattern of self-injurious behavior is different among those. So it's a very important distinction. Thanks, Dr. Goldberg.
Okay, well, if there aren't any more questions, I'm going to thank Dr. Veerakumar again for presenting, always saying yes when we ask him. So thank you so much. And if anyone would like to contact him, you can just send me an email and I can connect you with Dr. Veerakumar, his email address as well. So thank you again.